So I'd like to welcome everyone here to the Brown Bag session with the Center for Rural and Migrant Health. And we are located on the West Lafayette campus of Purdue University. The goal of these Brown Bag sessions is to connect university faculty and staff and community-based organizations to resources and collaboration opportunities within the rural and migrant space. This is being recorded, and the link will be put up on the College of Health and Human Sciences YouTube channel, and it will also be included in the follow-up email. I also to say that we'll see how the conversation goes, and there will probably be edits, but there will be some approved slides and informational flyers that will go out. The next webinar event is scheduled for January 20th, 2026, and it's on addressing substance use in Indiana, focusing on rural communities with Dr. Jennifer Brown. Today, our topic is rural health policy, the ever-changing environment of rural health policy. And our presenter is Dr. Cody Mullen. He's a clinical professor and director of graduate professional studies. In this role, he works closely with industry partners, faculty, and students to deliver both the MHA and MPH programs. Dr. Mullen is committed to ensuring graduates are prepared to make a meaningful impact with their future employer. Prior to joining Purdue, Dr. Mullen worked at the Indiana Rural Health Association, IRHA, as its Policy Research and Development Officer. With IRHA, he served as a project director and evaluator with projects focusing on infant mortality, chronic disease management, and telehealth. Dr. Mullen's research focus surrounds the application of scientific and engineering principles and theoretical frameworks to examine trends, impact patient outcomes, and improve care coordination in the realm of health services and patient-centered outcomes research. His expertise lies in project development and execution in diverse acute care and outpatient settings, including rural, urban, and resource-constrained communities. He's also an associate director of the Center for Rural and Migrant Health. So we're really glad that he took the time today, and I look forward to hearing what he has to say. Dr. Mullen?
Thank you, Susan, and thank you all for being here. Of course, the screen doesn't want to cooperate. Do you see the appropriate slide, Susan? Wonderful, thank you. I'm going to go ahead and open the chat, but we are a small group today, so if you do want to unmute and ask questions or have discussions as we go on, please feel free to do so, or pop this in the chat. I do have those open. It's a pleasure to be with you all today during this lunch hour. I just snarfed my lunch down before now to talk, but it really talk about rural health policy in a time of change. I do want to highlight that these slides were finished about 9:30 this morning. I have not checked the news since then, so some of the information I might say may already be out of date as it relates to the government shutdown and the reopening of our government. But before I dive into the remarks, I really want to just say, with respect and honor and gratitude, thank you to our veterans on this 11th day of the 11th month at the 11th hour when the guns fell silent. We thank you for the service that you have given to our country and allowed us to have the freedoms that we have today. So thank you to all veterans on this call, or veterans in your family that have done that for us. So a little bit of agenda of what we're going to do. So first off, I want to start with where are we? I know there's a wide audience on this call. Some work in healthcare and know a lot of what I'm going to say maybe better than I do. And then there might be some others who this is new information to them. So I want to level set of where are we as a country when it comes to rural health. I want to talk a little bit about private health insurance, Medicare, and Medicaid very quickly. So the more detailed discussion of where do we go from here and the current policy topics of today make a little bit more sense with that background. So where are we? Well, healthcare is not surprising. It is a large portion of our economy. Over the years, 2024 data should be coming out next month and next month's health affairs, so we can update this chart. But healthcare has been averaging about 17.5% of GDP, gross domestic product, as a country, except for during the pandemic when it did see a spike, both a spike in spend, but also a decrease in how much we were spending on other things as we were going through the pandemic as a country. If you listen to economists and as they talk, we know that this is not a sustainable piece of growth for our country. We need to control healthcare costs, but there are many different ways that we can address and do that. If we look at the spend that we have on private health insurance, Medicare, and Medicaid, for those of you who are newer to healthcare, private health insurance, so this is primarily what is received either through the marketplace that you purchase on your own, or that you receive through an employer, either as the employee or as a beneficiary, a spouse or a child, a dependent of someone who's employed. So private health insurance, it decreased for a little bit leading into the pandemic, not related to the pandemic, but then has seen a huge marked increase, now going up to about 12% growth in 2023. Medicare, the dark black line on this chart, has seen continuous and pretty much static growth of about 5%, 6% over the years. Medicare primarily, we care for our elderly, is how we remember that. So elderly, as defined by Medicare, which there's debates over that, but it's 65 or older, but also those who may have a long-term lifetime disability and stage renal disease or Lou Gehrig's disease. And then Medicaid, we've seen significant growth in that as well. These are generally our low-income individuals who are sponsored through the state program. Children or are age blind and disabled have also qualified. And we'll talk a little bit more about each of these programs in detail. But regardless, notice in 2023, every program had at least an 8% growth, if not reaching up to 12% growth. So what does this mean for us as consumers? We know that things are getting more expensive. I bought my turkeys for Thanksgiving on Sunday at Meijer. If you're looking for a big bird, just be forewarned, there's a shortage of bigger turkeys, we found out, so we had to get two smaller turkeys. But the prices of things that we spend by are going up. Medical care, though, is going up much faster at a faster rate than what we see in overall economy. And that's being felt by everyday consumers. It's being felt by Purdue employees as we go to the pharmacy. It's being felt by individuals on Medicare and Medicaid who may be on a fixed income. It's being felt by all of us. Our deductible, what we are responsible as an individual to pay, is going up. In 2006, is about $500. Now it's about $1,700. That's a significant growth of $1,200, but incomes have not gone up. In addition, employers have actually, from a national average, have absorbed more of the increase than what workers have observed. So again, all these things coming together, healthcare is not sustainable. And as we look at the government shutdown, that may be ending as early as tonight or tomorrow. I think the House has planned to vote tomorrow at 4 p.m., and we'll talk about that in a minute towards the end of our presentation today. Healthcare is at the forefront of that. The main issue the Democrats had back on October 1st when we entered the shutdown and they didn't pass the continuing resolution from the House at the Senate level was this idea of ACA marketplace and the expansion and what that really looks like moving forward. So let's dive a little more deeply into rural health and rural healthcare. So a lot of my slides are from other presentations that other people have given, and hopefully, so you may have seen some of these information, but trying to weave a different narrative or a story across all these different data points that are coming together. So every year in February, the National Rural Health Association, which I'm honored to serve as a board of trustees of right now, they have a policy institute in DC or in Arlington last couple of years, and they update the data where actuaries look at the hospital cost reports and say, what's the risk of hospitals closing and how many hospitals have closed? So as of February of 2025, so this is before some of the new initiatives under the Trump administration have taken place, we've had 188 hospitals have closed since 2010. If we look at the states, the darker the color here, the more closure that has been seen. Disproportionately, the closures are in states that have not expanded Medicaid under the Affordable Care Act back in 2010 to 2014 when that law was being implemented for its first time. So Texas, Oklahoma, Kansas, Missouri, Tennessee, Mississippi, and Georgia have seen 10 or more hospitals each close. If we look at predictors, what aspects of those hospitals that have closed makes us worry about future hospitals closing? Again, this is February before One Big Beautiful Bill, the shutdown, and different changes have occurred. We thought there's 432 hospitals, rural hospitals, who are vulnerable to closure. Notice again, it is that Delta region, that southeast to south central portion of our country, where we disproportionately see a higher risk of hospitals closing. And those darker colors that we see in Arkansas, Mississippi, Tennessee, Florida, and Kansas, that's a 41% or more of their rural hospitals are at risk of closure within the next year. That's staggering. Again, this is before One Big Beautiful Bill, and we'll talk about that moving forward coming up. We also look at rural hospital closures that has effects on other services. behavioral health. So not only do we have a substance use or substance misuse epidemic that has started since 2014 to 2016 and has ebbed and flowed, but still a significant concern. We also see that our kiddos, our pediatric population, has significant mental health needs, and then our working population has significant mental health needs as well. And the ability to access behavioral health providers in rural is getting much, much more difficult. And we see again the states that we saw highlighted to closure, high risk of closure, but also I want to highlight here darker is bad. Indiana is the darkest color. So as you think of a state, from a rural health standpoint, there's that part of me. There's a lot of different other slides that could be shared around OB deserts, other services that are changing. Becker's just did a whole article update yesterday about how many OB services have closed. I'll just didn't want to put up a slide, but just a quick statistic. So we have 92, 93 counties in Indiana. I always forget, sorry. But 92, 93, about 50 of those counties either don't have a hospital or don't have an OB unit. So over half the counties in Indiana do not have a facility that is able to deliver in. Now we have the ability to access, we're an hour from an urban center, but I don't know about you. Sunday night, I went out driving. I had to get a few things at the grocery store. The weather had set in. It wasn't even that bad of weather in the grand scheme of Indiana for us, but the roads were awful. I definitely don't want to be in an emergency situation or an urgent situation trying to navigate those roads. So what I want to do for the next maybe 10 to 15 minutes, and then we'll get to current events, is talk through different aspects of private health insurance, Medicare, and Medicaid that are going to then link back into current events that are occurring around those. So we start with private health insurance. So a reminder, private health insurance disproportionately is provided by employers. So someone in the family is employed at a benefits eligible position. They receive health insurance through the employer. They then cover their spouse. If their spouse doesn't have access to health insurance through their employment or if they're unemployed, and then the dependents they have, usually their 18-year kiddos, are also on the plan. So a huge portion there. There are some marketplace plans that are also private insurance that the consumer covers the full premium, the cost of that plan with subsidies from the government. But really, this study that we're going to look at with the RAND study is looking as employer-based. So in 2017, Indiana was the leader of this, and they said, we want to look at what are the prices of private insurance and how do they compare to Medicare reimbursement. So we think through the three payers, private, Medicare, and Medicaid. Medicare is always kind of the gold standard. We always say that Medicare, we base everything off of what Medicare does at the federal level. Private insurance is higher than Medicare reimbursement. Medicaid is lower. Majority of hospital reimbursement, Medicaid usually pays at cost or below cost. Medicare is usually at cost, maybe a slight margin, and then private insurance is usually where the margin is made. I'm not saying profit and gross profits there, but really the margin of the operations, the things that are not reimbursable that the hospital, through EMTALA and other reasons, are required to provide. This not only is true for hospitals and inpatient care, emergency department care, outpatient care settings as well. So what Indiana really wanted to do is the large employers, Purdue is one of them, IU, some of the large manufacturing, Subaru and Lilly and Cummins, they're self-insured. So Purdue partners with Anthem to manage their insurance, but Purdue is writing a check. If I go to the doctor, Purdue is paying that. The risk is being pooled within Purdue. So they have all the data of what is really being paid for each time I go to the doctor, any of my colleagues go to the doctor, any of our families go to the doctor to look at that. And they did a very simple ratio. Private health insurance plan claims, what was paid, divided by Medicare allowed amounts. So if Purdue paid for me, for example, the same amount as what Medicare paid, the ratio is 1. Greater than 1 means that private health insurance is paying more than what public health insurance or Medicare is paying, and less than 1 means that Medicare is paying more. And they did this study back in 2017. I purposely have blinded the facilities, but if you go out, this is a publicly available report, or if you email me, I'm happy to send it to you. That white bar that looks like I have a gap in my graph, that's really hospital names. And I don't want to share those, but again, it's publicly available. You can go out there and get there. So the bar on here, the line bar, that is the inpatient plus outpatient average for each health system. The solid colors are health systems. So think Parkview, IU Health, Ascension, Franciscan, Community Health. They're each one of those. And then the hollow bars that we see towards the center and the left side of the graph are the averages of small rural hospitals that are not system owned. So think Putnam County General Hospital or Greene County General Hospital. The left side is critical access hospitals. The right side is rural PPS hospitals. And during the questions and answers, we can get into the weeds of that if we'd like to. The dots are inpatient care, so notice inpatient care is lower, and then the triangles are outpatient care. And then the solid line is at 1.0, so that's at what Medicare reimburses. So we see a huge range here of these things of 1.21 at the lowest, so 21% more than Medicare reimbursement, all the way to the right side of the graph at 3.7 or 370% more. And that outpatient care, that triangle, if you can't read it through Zoom, which I know it's tiny print, that's 4.96. That's 5 times. So every dollar Medicare would pay, private insurance for the employer is paying $5. Looking through the attendees here, I know there's a lot of healthcare employees present on here as well. There are some methodological flaws with the study. There's a lot of things not being incorporated with the study. But regardless, this is a very popular study, and this is something that our elected officials at both the federal and the state level, when you're talking to them, they bring up the RAND study and these numbers very, very frequently. I'm going to draw a magic red line here, and I want you to remember that line because it's going to come back future with some other slides we're going to have as we talk about current events. So the RAND study, like I said, was done in 2017 with the state of Indiana. Indiana said, okay, well, we are one data point of 50. Let's expand this to other states. What do other states look like? Are we an outlier on the good side? Are we an outlier on the high cost side? Are we right in the middle? So that was done. We've done 4 more studies. We, mean the nation, not me, Cody, have done 4 more studies with 25 states, 49 states, 50 states, 49 states. Notice that Maryland is excluded because Maryland has a very unique way of paying for its health care. A lot of pilot programs, so some of these analyses don't make as much sense, so they've been excluded. And in 2024, so only a year ago, when the newest report came out, a new methodology is implemented as well. So we look at RAND 5.1, and we look at the same averages over the year from a national average. So these are 49 states. We see that pink line is the overall line. The purple line right below that pink line is our inpatient. The green line is our outpatient. And then Medicare is all the way down there at the 100% mark. So we've seen from 2020 to 2022, overall, we've gone from about 240% to 252% of the national trend. That report then lines you up by state. So highest cost state using this ratio on the far right side, lowest cost state on the far left side. So Arkansas, Mississippi, and Michigan are towards the lower end, below 200% as a state average. And then all the way over on the other high side, you have Florida, West Virginia, and South Carolina. And where is Indiana? I'm using my mouse. Hopefully you can see that. Indiana is right over here towards the right side, if it arguably the start of the tail up. Again, I share all of that for you. We can debate the methodology, but really we'll bring that back in some discussion of current events that are occurring for rural hospitals moving forward. Okay, so that's private insurance. Let's do a very quick overview of Medicare. Remember, Medicare is for those who are 65 or older, so age-based qualification. Those who have permanent disability is defined by Social Security. So disability ranking or a diagnosis of end-stage renal disease, meaning kidney dialysis is needed, or Lou Gehrig's disease. And primarily those two are just because of the huge cost associated with treatment. We want the risk pool to be as wide as possible to support those individuals. So a national risk pool makes sense versus a state or private plan. In Medicare, a major talking point that we're seeing at the national level is this idea of Medicare Advantage. This is the privatization of Medicare. So instead of going and getting Part A, Part B, and Part D through Medicare as a traditional, maybe a Part K or J plan as a supplemental, I'm going to instead take my Medicare benefit, partner with a private health insurance company, an Anthem, an Aetna, United, an Optum, whatever, and they're going to provide my health insurance. It's going to work a lot more like how I'm used to health insurance working with traditional premiums, traditional copays, and deductibles. But now hospitals, instead of getting Medicare reimbursement for Medicare Advantage patients, they're getting the negotiated rate that they have with that Advantage plan. Back in 2007, that was about 20%, 1 in 5 individuals on Medicare were on Advantage. But in 2023, 2024, the tipping point occurred where now majority of Medicare is on a Medicare Advantage plan. This has created for rural health a lot of concerns and a lot of policy actions need to be taken. And we'll talk about some of those with the One Big Beautiful Bill of hospitals are saying, I can't afford Medicare Advantage reimbursement. It's less than traditional Medicare, which is already at cost or slightly below cost. So how do I balance those two things out? If you read the transcripts or watch the testimony of Dr. Oth, and who was confirmed as CMS administrator, the current administration sees Medicare Advantage as a huge solution moving forward because it's a way to have a fixed cost. Medicare now knows that the Advantage has the risk, and there's a flat fee or per PMPM per member per month payment coming from Medicare for majority of these. We look at who are the ones covering and going on Medicare. So the top bar chart, 29.7 million, is traditional Medicare. So majority of these individuals have a Medigap plan, or they're still on their employer plan, or they are what we call dual eligible. So they're on Medicare and Medicaid. But we look at Medicare overall, there's a large portion, or Medicare Advantage, pardon me, there's a large portion of dually eligible Medicare and Medicaid. Some that are still an employer, but that general enrollment, which up above is about 0.3 to 3.5 million individuals, is 17.5 million. So these are your traditionally your age-based Medicare qualification individuals who sign for Medicare. And I don't know about you, I have elderly parents. We're still on a family plan. The amount of spam calls I'm getting right now during open enrollment for Medicare Advantage. Yesterday was 38 missed calls that I had, and they are all spammers. I'm guessing for Medicare Advantage, or I had a new funeral benefit that I could have taken advantage of as well. So a huge market here for that. Okay, last little review slides, and then we'll dive into some of the current events and have a discussion. Medicaid. So Medicaid is a federal and a state program. Majority of the funds from Medicaid come from the federal government, but the state manages it. In the state of Indiana, that is through the Indiana Family and Social Services Administration, FSSA. How do you qualify for Medicaid? It's a needs-based program, so based on income. That income threshold is different depending on who you may be. So if you are and what the news is using a lot in the vernacular, an able-bodied adult. So that is someone who has no disability, no blindness, or no older age above 65. They qualify usually at a certain threshold at a poverty level. That threshold may be increased higher if you also have a disability, if you also have blindness, or if you are a kiddo and go onto the CHIP plan. We look at One Big Beautiful Bill, a lot was for Medicaid reform, and we're going to dive into how that may affect Indiana. So what that is so Medicaid is, again, state managed, but majority of the funds are federal drawdown funds. And this is our FMAP, our Federal Medicaid Assistant Percentage. This is based by the state, based on what is the need and the health of the state. For some states, the lightest color here, the minimum match is 50%. So for every dollar spent on Medicaid in California, 50 cents comes from state taxes, 50 cents comes from federal match dollars. If we go to other states that may not have the same level of health as California does, these are darker states, we get as high as 75 to 80 cents as an overall FMAP. There's other carve-outs for ACA expansions and things like that that can be as high as 90-10. Indiana's FMAP right now is 64.5%. So for every dollar spent on Medicaid, 64.5 cents, 65 cents for easy numbers comes from the federal government. 35 cents comes from a state match, or state taxes that we pay. The state that has the best FMAP is West Virginia at 75 cents to 25 cents. So as we're looking at some of these newer pieces of legislation moving forward, a lot of discussion is, what do we do to the FMAP? What if we lower the FMAP at the federal level? That means less federal dollars are leaving the federal government and going to the states, and then states would have to increase their taxes, potentially to include the same level of services, and or decrease the level of services because of less revenue coming in. If we look at who is on Medicaid and how we expend this, so this is from 2021. So this data is a little bit old and a little bit biased because this was the pandemic. 2021 was still very much the pandemic. If we start at the bottom, so 10% of our enrollees in Medicaid as a national average are individuals eligible based on age. So they're 65 and older. They account for 20% of the expenditures. These are most likely individuals who are dually eligible. So Medicare is covering their physical health, their behavioral health needs. Medicaid is covering their long-term care services. So their nursing home, their skilled nursing, their home health is on Medicaid. Next percentage is 13% are individuals who are eligible based on disability. They account for 31% of the expenditure. Again, probably because of a high utilization of long-term supports and services. So in-home services or facility-based services, a nursing home, for example. 20% are other adults. These are people who income was 100% or below before the expansion of Medicaid through the ACA. They account for 13% of the expense. 23 to 21 is our ACA expansion adults. Not every state chose to expand their Medicaid to have these, but the FMAP was really, really high, so states took advantage of that. Indiana, this is what we call HIP 2.0. This is our way of expanding Medicaid up from that 100% at federal poverty level to 133% federal poverty level using the HIP program. This is the large discussion that we see in the news media across multiple news sources about able-bodied adults. Are these 20 and 23% of do they need to be on Medicaid? And if they are on Medicaid, should there be other requirements? And OB3 has added new requirements to these individuals. And then 34%, about a third of our Medicaid population are kiddos, children, but they are relatively inexpensive to care for. They don't have the chronic condition per se that we as working age adults or our elderly do, but we have them on there. We also have a higher threshold. So CHIP is a 200% poverty level versus adult at 133%. So it is possible that the kiddos in the family could be on Medicaid while the adults in the family could not be on Medicaid. When we look at our spend per beneficiary, Indiana is not the highest, so we're not number one here, but we are expensive. $7,000 to $9,000 is spent on a beneficiary. Lowest states are below $5,000, and we see that primarily down the South. If there's a correlation with hospital closures, we can talk about that during our discussion. And then Medicaid enrollment over time and Medicaid spend. This has been zigzagging over the last since the turn of the millennia. In 2000, what we're seeing, our enrollments are increasing and our spend are increasing, and that is a big, big discussion. So take a deep breath. So that's all the background. So if you're like, okay, I'm not a health policy person, hopefully this will help bring you up to speed for some of the discussions that we're going to have moving forward. So where do we go from here? Well, I think right now we look at 2025, we look at 2026. As of right now, and I've not gotten a text message, and please, people that have my number, text me if I'm wrong. But I believe our government is still in a shutdown status. We shut down at midnight on September 30th, so about 41, 42 days ago, because we needed to pass either a budget, which did not occur, or we needed to pass a continuing resolution, which did not occur out of both chambers. And the main talking point around this, there are several, but the main talking point was this idea of ACA expansion. So when ACA was passed, or Obamacare, in March of 2010, not only did we expand Medicaid up to 133%, but we created an exchange that was easier for individuals who needed to buy health insurance who did not qualify for Medicaid, but didn't get through their employer. And if you made between 133% of the federal poverty level and 400%, there's subsidies on your taxes that would help offset the cost of those premiums. And that was a sliding scale based on where you were in that overall span. There was additional subsidies that were added in during the COVID era when people weren't working, and there's more use of that. And those are set to expire at the end of 2025, so December, the end of this benefits year. The Democrats really advocated for the expansion of those, and they were not willing to pass a CR back in October without those expansions occurring. From what we're seeing now is it looks like the government will reopen, a CR will be passed. I am still a little weedy on the details on that, missing a few of those details. But the expansion of those tax benefits for the ACA expansion have not been tied to the votes that occurred in the Senate late last night, and the House tomorrow at 4 p.m. is the vote that's being planned as of now. Instead, a special vote will be done on those in December. By December 12th, I believe is the deadline that Majority Leader Thune has set for that. So be watching that. It also means that the ACA marketplace, which is in an open enrollment right now from November through, I think it's January 15th, is calculating premiums if those expansions are not going to, or extensions are not going to occur. So we're seeing marked increases in premiums. We're talking premiums that used to be 10, 12, 15, $150 rising all the way up into four-digit numbers. So there is concern that families may not be able to afford $12,000 a year in premiums for a $10,000 deductible plan. So what does that look like? So strongly encourage, if you want more information on this, happy to have a discussion. But Kaiser Family Foundation has put out a lot of exposés and data analyses of what this looks like and what the overall cost could be. The government is going also into a midterm election cycle. So 2026 is an election year. The full House is up for re-election. A third of the Senate is up for re-election. Texas has changed their boundaries, so there's new districts in Texas that will be a part of the House election. Indiana has called a special session that will meet starting in December to potentially change our lines, which means we could have new districts in election. Prop 50 in California was passed election night last week, so lines there could be changing. So the makeup of the House could look very, very different. It may not swing political parties. It may still be Republican controlled, but the Republicans there and the Democrats there could be very different as we see new lines. So what are some of the current things happening? So the One Big Beautiful Bill, or OB3 is what I will call it for ease, that was signed into law on July 4th of this year. It had a significant healthcare component to it. Arguably as much as, if not larger than what the ACA did to healthcare. And the majority of OB3, while there are, and we'll talk a little bit about some of the Medicare provisions within it, it primarily changed the way the Medicaid program worked. There are a lot of actuaries out there, a lot of economic groups, a lot of research centers. Our center was not one of them, but quickly did the analysis of, with these changes, what's the anticipated change in revenue for rural healthcare providers? And the number that majority have come out, that majority are using, is there'll be a decrease in Medicaid reimbursement over the next 10 years of $200 million for rural facilities. That's a fifth of $1 billion change to our rural healthcare facilities. I go back to one of the first slides I showed and said there's 480 some odd hospitals at risk of closure, but that was before the OB3 analysis and the OB3 was passed. There are a lot more hospitals now at risk of closure. In Indiana, the analysis is saying 10 hospitals are at risk of closure as OB3 comes into effect. So in rural, one of the big policy things that occurred was the creation of this rural transformation funds. $50 billion was added into OB3 specific for rural transformation. 25 million will be equally split across the 50 states that apply for the funds. All 50 states did apply. So roughly that's $500 million per state. And then the remaining $25 billion will be split amongst states based on need and other metrics there as well. There's a lot of discussion. Is that fair? Is that equitable? But one example I heard is Rhode Island got as much money as Texas. So if you think of how many rural facilities are in Rhode Island, I think there's two, maybe one. And how many rural facilities are in Texas, there's a disproportionate support there. So that remaining $25 million will be split. This is a screenshot from CMS's website, so these are their words, not my words. But their strategic goals for these funds is to make rural America healthy again and sustainable. So as we're seeing a reduction of $200 million from the system, let's infuse $50 million of unobligated funds. They're on grants, there's obligations, I get that, but not through reimbursement of services that allow rural facilities to reimagine what does rural healthcare look like. What's the evidence base and outcome drivers of rural healthcare for disease prevention, chronic disease management, prenatal care, behavioral health care, and how do we make that sustainable? And let's do that in 5 years. So OB3 passed July 4th, 2025. The notice of funding opportunity came out early September, right after Labor Day. The grant applications from each state were due last Wednesday. That would have been November 5th. Funding decisions should be released by the end of the calendar year, so December 31st, and project period starts January 1 and then runs for 5 years. There are plans for no cost extension, so really these funds will probably go out for 7 years, but really looking at how do we make rural America healthy again? How do we have sustainable access? How do we get the workforce where we need that workforce to be? How do we create new innovative care with new payment mechanisms, including ACOs and other value-based care? And what new tech is out there that would support rural facilities? Again, we're anticipating mass rural hospital closure before this. Now there's less funds. We're anticipating even more rural hospital closure. So something that we as a rural health community are going to need to prepare for is that rural healthcare is going to look very different in 5 years than it does today. The idea that an inpatient hospital will be in every community and do a full scope of service is probably a thought of history. As we're transitioning into maybe as a standalone emergency department with robust EMS to transport into the urban tertiary center or even the secondary care center for support there. Maybe that's a higher utilization of telehealth. Maybe that's a change in other things, but things in rural are going to look very, very different. And we're on this ride now for that. States must use the funds for 3 or more approved uses of funding. Here are lists of those approved funding. So provide evidence base on different things and technology. Every state had a different approach for how this works. So Indiana FSSA led our application as a state. Um, I don't have a lot of details of what was in that application. Other states, their whole application is on their website. So Virginia, someone through, I think it was APHA, he got his hands on Virginia's and he emailed it out to the listserv of rural people at APHA. So we were all able to go, oh, this is exactly what they're proposing to do. Other states, don't know anything. Indiana had a committee of external stakeholders along with internal government stakeholders that work through the application process and are waiting to see how CMS responds to that before, I think, making a lot of big changes and big announcements publicly about the use of the funds. So that's one piece of OB3. Another piece is there are some Medicare changes that are coming through this. So looking at how do we change Medicare reimbursement, delaying some final rules that were set to go into effect in 2024 and delaying them out for 10 years. Some significant updates to physician fee schedule, looking at the rural emergency hospital, the REH model, which is a non-inpatient care-based hospital, and changing those. Changing payment models under consideration in Center for Medicare and Medicaid Innovation. So having more upside and downside risk models in reimbursement. And what does that look like? We're seeing some large announcements. Just last week, we saw that Lilly was one of the first companies to partner with the Trump administration on Trump RX, and that is the official name. That's not meant to be slang, but the Trump RX plan that would allow for GLP-1 inhibitors to be at reduced cost, both for Medicare population, but the general population. President Trump, in his first term, started drug price negotiation legislation. It did not pass. President Biden did pass drug negotiation legislation. President Trump now in term 2 is really running with that. So how do we negotiate drug prices and what's that look like moving forward? We look at Medicaid, that could be a whole discussion, a whole 1 hour discussion. I thought one of the best ways to kind of show the breadth of this is taking a screenshot of the American Medical Association resource guides and just kind of variety of these things. So eligibility for Medicaid is changing in OB3, who will be eligible, who will not be eligible. The work requirement is a large component of this. So when we talk about the ACA expansion population, or as the media is saying, the able-bodied adults, they're required, if they're going to stay on Medicaid, to have a 20-hour-a-week work, volunteer, or school commitment continuously to stay on Medicaid. So they must go out and get 20 hours of employment for that. How that will be tracked will be done at the state level. So we're still waiting on guidance to come out from Indiana FSSA of what that will look like, recertification, the frequency of that. But then also discussion, what is volunteering? Is that a very formalized volunteering through an organization that is certified by the state to be a volunteer organization? Is that something I can go out and accumulate hours and self-report for education? What's that look like? What's that definition? And then working, as you work more, part of that is then you will have more income and you may not be as eligible for Medicaid as your income increases. So balancing that work requirement. SNAP has been in the news much more recently than OB3, but updates to SNAP and the food assistance program there and what that looks like, changes to CHIP enrollment for kiddos, these ideas, these rural transformation plans, changes to the marketplace and eligibility for marketplace. And then also some changes to student loans. As an education institution, we cannot forget the change to student loans, the caps that will now be existing for graduate level education, which involves medical school or other type of training. So I think we have a lot of changes that will be coming forward with blah, 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 with different aspects of that as well. The other thing that I didn't add to this slide, but I think is another thing that we need to track at a federal level of policy and changes is the H-1B. So it's a $100,000 application fee now for an H-1B. Disproportionately, H-1B doctors work in rural compared to urban. So rural facilities are already seeing 150 million, $200 million reduction in Medicaid reimbursement, a reduction in Medicare reimbursement, a reduction in private health insurance reimbursement as less people are on the marketplace. Will they be able to afford that fee for the H-1B visa to come in? And then what will that do to the ability of services if we have less providers? Couple more slides real quick. So this is a slide from Indiana FSSA, their quarterly financial review meeting that was done on October 29th of this year, presented by Secretary Robb. Pulled this slide from Indiana Chronicle. But Indiana is now looking at this RAND report. So remember when I said, remember that 265% line? That's the dotted line here. This is where all the Indiana hospitals are with the most recent data that he presented as well. And there's now legislation that we will reimburse hospitals. So class 1 hospitals, which is primarily rural, they will be excluded. Those are the blue dots, but the orange dots, class 2 and class 3, if they're above this 265% threshold set by legislation, their Medicaid reimbursement will be further reduced. So not only will they see reductions from OB3, but Indiana will also be reducing that to try to get costs down. Happy to get into discussion of what that looks like moving forward as well. There's a lot there to unpack as well. And then our current government shutdown. Like I said, so these are screenshots from the Wall Street Journal, the New York Times, the Washington Post. This morning, as I came into the office, we are nearing potential reopening of the government after a 41-day shutdown. But the ACA expansion credit that we were hoping would, or the Democrats, excuse me, were hoping would be part of that reopening is not something that's being discussed at this time. There'll be a separate vote for that to occur after the Thanksgiving holiday. I've lost track. I'll be honest. I tried to find it, but there's so much coming out so quick of how long until the next shutdown could occur. Of the CR, I've seen January, I've seen March, so I don't have a clear answer on that personally. But I mean, this is just reopening the government. That still means we need to pass a budget and things like that. So Carrie Cochran McLean, Dr. Carrie Cochran McLean, who's the chief lobbyist and policy affairs official for NRHA, she came and presented at our symposium back in September, and these are her slides. But just to remind you, these are the fiscal year 26 appropriations of the Senate once and if a budget is approved. And that's the whole point of the shutdown. So we're seeing pretty much status quo funding for rural health, a little bit on the Senate, a little bit of an increase to the State Office of Rural Health, a little bit of an increase to the Rural Healthcare Services Outreach, so that's a HRSA funding mechanism, but seeing a decrease in behavioral health workforce development and other areas like that. We also have a reorganization of HHS at the federal level. The goal with the fiscal year 26 budget was to wipe away several agencies and combine them into the Make America Healthy Again agency, or Make America Healthy agency, I think, MAHA. So how will that play out? Right now, like a lot of focus is on to reopen the government, but we saw the whole budget appropriation process and discussions of those changes. The House has a little bit different approach with that. The behavioral health workforce training grants are not decreased as much. They increased on the rural health stabilization. These numbers came out after OB3 passed, so we're not sure what changes there could occur, but something that we really want to make sure we keep an eye on. So with that, thank you. I will, my email is on here. Susan will also, the rural at purdue.edu goes to our team and can get to me as well.